Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, Dr. Renslow Sherer discusses a case scenario of managing a first ART failure in a patient with COVID-19. Dr. Sherer is the director of the International HIV Training Center and a professor of medicine at the University of Chicago. For more information about Dr. Sherer and this program, and to follow along with the slides, please visit the links in the show notes for this episode. Now let's get started and hear what Dr. Sherer has to say about managing a first ART failure.
The first ART failure in a patient who also happens to have COVID-19. This is the 45-year-old woman diagnosed with HIV in 2010. Part of her past medical history is methamphetamine use, housing insecurity, known to have dyslipidemia, and has received COVID vaccinations. The last one was about 8 months ago. And she returns to clinic having been off antiretroviral therapy and with thrush as a new diagnosis. And you see that compared to her baseline, her T cells are now 21, virus load's 230,000. She still has wild type HIV genotype. Her core antibody and surface antibody to hepatitis B are both positive. Her hepatitis C antibody is negative, creatinine's 0.7. She has an LDL of 210 and a HDL of 32. In terms of her treatment, we know that she started on efavirenz, TDF, and FTC with virus loads less than 50 for 2 years. She was switched to the newest at the time integrase inhibitor elvitegravir, co-formulated with cobicistat, FTC, and TDF. Again, with good suppression for a year. And then in 2014, with the use of methamphetamine and with homelessness, had repeatedly detectable HIV RNA and then was lost to follow-up. And a single genotype provides really invaluable information in this case with substantial nucleoside resistance with K65R and the M184V, no mutations to non-nukes and PIs, and 3 integrase resistance mutations, notably the Q148R. So, what does the DHHS guidelines tell us about managing virologic failure? Certainly, I would encourage everybody to have a mentor or an expert who they're able to run these cases by, to talk about them with. These are complicated and I think are always challenging for any HIV clinician. If we think about the ways that we evaluate patients, obviously adherence is the most common reason for virologic failure. And clearly we had some issues to point to with drug use and housing instability here. I would also focus on drug tolerability because among the most common causes for poor adherence is difficulties with tolerability. And so were there issues with the past regimens that might have contributed to poor adherence? It looked like there was actually a few years of good adherence with good tolerability. So when we think about resistance testing in the setting of virologic failure, we need it before discontinuing the regimen. We need it within 4 weeks of discontinuing the regimen if someone's not on long-acting antiretroviral therapy, and any time after discontinuing the regimen if someone is on long-acting. And that, of course, is because there's sustained drug levels that can be for as long as a year with the long-acting cabotegravir-rilpivirine combination. When I think about the past treatment history, all the previous genotypes and phenotypes that are available, and also recognize that standard tests don't always detect archive resistance. In our patient, for example, when the first virus load was assayed at 230,000, this patient showed wild-type virus. But we know because of the archive resistance that, in fact, we have to be very careful in choosing the next regimen. Often these standard tests don't detect drug-resistant viruses that can constitute less than 10 to 20% of the regimen. So if we think about the types of drug resistance testing, certainly the first test that we should always do is a genotype. It's quicker, it's less expensive, it gives us the information we want, which is what resistance mutations are present. There are patients with more complicated treatment histories, particularly in second, third line failures and later, where a phenotype can add additional information and where I would recommend both genotype and phenotype. And then there's some settings where it's useful to take someone who has a low virus load and to do a proviral DNA genotypic sequencing assay to try and identify if there's any archived resistance mutations. If you get a positive result from that test, I think you have to take it seriously, but we need to appreciate that these proviral DNA assays have a high failure rate. In one very well-known study, 50% of the time it missed detecting an M184V resistance mutation, for example. So you take it with a grain of salt. If that shows no resistance mutations, it doesn't eliminate the possibility that they may indeed be present. So if we return to our patient, this was a look at our patient through the Stanford database resistance interpretation. And clearly there's high-level resistance to abacavir, FTC, and 3TC. Though we remember the M184V with resistance to FTC and 3TC means we still get substantial antiviral activity of about 0.5 logs, and we still have a very important impact on viral fitness. And that's why we see 3TC and FTC used recycled in subsequent regimens. But the patient was intermediately resistant to tenofovir with a K65R and susceptible to zidovudine. We'll talk more about that in a moment. Fully susceptible to the non-nukes, fully susceptible to the PIs. And then you can see the difference that basically there's high-level resistance to the first generation integrase inhibitors and intermediate resistance to dolutegravir and bictegravir. You may get a contribution with the use of that class of drug to a next regimen. If, for example, in the case of dolutegravir, a twice-daily dosage is used. So back to the guidelines, they have some very specific recommendations when it comes to first regimen failure. The first is not to add a single drug to a failing regimen. So that's clearly what you don't do. What we're trying to find is at least 2 fully active antiretroviral therapies, particularly if one has a high resistance to barrier to mutations. That is in the example of either dolutegravir, boosted darunavir, or bictegravir. And there are some instances where even if you have a single fully active new class of drugs with a high resistance barrier, and then you use 2 partially active nukes, that is a suitable alternative. And if it's possible, 3 fully active drugs are the best way to go. So how do we define fully active? Well, that means no predicted resistance based on what we know from the treatment and failure history and from resistance testing. A novel mechanism of action, not likely to be affected by past regimens. And then again, you can include some newer members of existing classes, the second and third generations, against isolates resistant to the older drugs. For example, etravirine or doravirine in the NRTI class, darunavir in the PI class, and then dolutegravir and bictegravir. Right, so let's look at some studies that will help to inform us. And some of the best studies in treatment failure in the modern era are being done in sub-Saharan Africa. This is the EARNEST study that looks at second-line therapy in people who failed 2 nukes and an NRTI, 1,200 patients who received a boosted PI. And the interesting finding here is that in comparison to a monotherapy with a boosted PI, patients who had paired with other nucleosides or with the integrase inhibitor raltegravir did better than those who were given a PI monotherapy. And I think we've learned in many different studies over the years that boosted PI monotherapy, even though it has remarkable activity, is not a sufficient form of therapy, that we should always pair it with another medication. And here you see that either pairing with an integrase inhibitor or with nukes with varying activity it led to a better than 80% success rate with full virus load suppression. And very interesting, even in that group that seemed to have 0 active NRTIs, that was 188 people where it looked like they had predicted no activity, they did every bit as well as people who had either 1 or 2 to 3 active nucleosides. So the question that this study generated was, what's going on in the nucleoside class? Do these nukes maintain activity even when they're combined with a second generation integrase inhibitor, for example? And so there's a very nicely done study, the NADIA study, that addresses this question in sub-Saharan Africa. So this was a 2x2 factorial design comparing dolutegravir and darunavir boosted as the choices following first NRTI failure. So the entry criteria was someone had to be failing for 6 months with a virus load over 1,000 while they were receiving an NRTI with TDF in either 3TC or FTC. But then there was a second randomization, which was to receive either 3TC and tenofovir or 3TC and zidovudine. And this is important because the WHO guidelines at the time recommended that this patient be switched to a zidovudine-containing regimen based on their prior treatment history. And so their primary outcome measure was a virus load less than 400. And just to convince you of how heavily treatment experienced this group was, half the patients had less than 200 T cells, a quarter had a virus load over 100,000. And you can see that half the patients had a K65R, 86% had either intermediate or high resistance to M184V or I, 58% had intermediate or high tenofovir resistance, and 18% had some level of resistance to zidovudine. So what they saw was really two interesting and important findings. The first was no difference between dolutegravir and boosted darunavir in this group. So the primary anchor drug, the dolutegravir or darunavir, really didn't make a difference in the choice between those two. Certainly very good news for dolutegravir because of its greater tolerability compared to a boosted PI. But the second really interesting finding in this study was that in the head-to-head 2x2 factorial, looking at the nukes, the 3TC tenofovir arms performed significantly better than did the zidovudine-containing regimens. You can see those numbers are at the less than 400, 91% with TDF 3TC compared to 84% in the ZDV 3TC arm. Very interestingly, the 3TC and TDF arms did extremely well with high levels of efficacy, even though they had both K65R or N and the M184V or I. It's also useful to note there was a difference in terms of resistance, that in the dolutegravir arm, there were 9 individuals who developed resistance as compared to none in the boosted darunavir arm. So that led us back to the guidelines. This is the DHHS guidelines as of September 2022, talking about how you manage ARV failure with the second-line drugs. And so if you're looking at folks who are boosted PI and or dolutegravir susceptible, you can see that on the far left, if you're susceptible to both, you can use either dolutegravir or a boosted PI, and you could use boosted PI with an active integrase inhibitor, as we saw in the previous study, in the EARNEST study, in the arm that used a boosted PI with raltegravir. But if you're susceptible to a PI only, as in our case, obviously the first choice is boosted PI, and boosted PI with 2 active nukes, preferably. And if a boosted PI isn't used, then 2 or preferably 3 fully active drugs. And again, on the other side of the ledger, if they're susceptible to neither, then you would be trying to use 2 or preferably 3 fully active drugs. So the patient has said in this case that the patient's ready to restart medications. They're limiting the pill burden, and it's important to the patient because of prior adherence challenges and medication storage is concerned. So most patients, if they're given the option, favor the 1 tablet once a day option. So in this case, the choice was the boosted darunavir plus cobicistat FTC TAF once a day, TMP SMX or Bactrim DS 3 times a week. Reason to do it every other day is to reduce potential for adverse effects. A atorvastatin 20 milligrams a day. We've already seen high LDL and a history of hyperlipidemia. So that's the high intensity statin that will actually get benefit from boosting. And then because this patient has thrush, she started on an oral regimen with fluconazole for 2 weeks, as well as referral for assistance with adherence, substance use, and housing, and referral for completion of COVID-19 vaccination. And I would say, those of you who do this practice for a living, you'll know that if you can offer that and give it at the same time you're seeing them rather than a referral, your chances of completion are substantially increased. So clearly this patient has an indication for completing their vaccination. So the case goes on. There's a follow-up with good medication tolerance and adherence at week 4. The virus load is down to 1,400, a much larger than 1 log decline, as expected, and it's gratifying to see it. At week 8, the T cells are already up to 210. The virus load is 210, and the T cells are up to 81. And at week 10, the patient calls clinic and has 3 days of fever, myalgia, and a non-productive cough. And they've had a positive home rapid antigen test prior to having received any anti-COVID vaccine. So it's very reasonable. This is a person with advanced HIV who needs treatment for their acute COVID within the first 5 days, ideally. The simplest and the most effective option is the twice daily regimen of nirmatrelvir and ritonavir. And the NIH guidelines say, first of all, that this patient requires treatment because of having a high risk of severe COVID. And while there are drug interactions that would need to be taken into account, they would not prevent the use of this medication in this patient. So in terms of the atorvastatin, there is a drug interaction. Already this patient's levels will be elevated for having been on a cobicistat boost. And it's recommended that you hold the atorvastatin until 3 days after the completion of nirmatrelvir and ritonavir. That won't substantially alter the impact of their long-term statin therapy. In terms of being on boosted darunavir with cobicistat, there's no dose modification required, and there's no substantial interaction with the sulfa drug. So this is how that case played out. A patient was treated for the standard 5-day dose, stayed on darunavir, cobicistat, FTC, and TAF. The atorvastatin was held, so for a total of 8 days, 3 days after completing nirmatrelvir and ritonavir. There was full recovery from COVID. Week 16, the HIV virus load was undetectable. There has been substance abuse counseling, and the patient is currently in stable housing with a case manager. So that's a happy ending, which we don't always see, but the steps that were taken there were to take the full patient into account to try to help to address the social service needs, at the same time as effectively choosing a regimen that would be fully suppressive. That was a critical step in this patient's management.
Thank you very much to Dr. Sherer, and thank you to our listeners for joining in. As a reminder, to view the full Contemporary HIV Treatment and Prevention 2023 program on the Clinical Care Options website, and to access the slide set for managing ART in challenging scenarios, click on the links in the show notes for this episode. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.